welcome to the Lung Health Foundation's annual Influenza Roundtable with Dr. Dawn Bowdish. This is a discussion to help dispel any myths out there around the flu shot. Just for anybody on the line, and FYI, this roundtable discussion is being recorded. My name is Daniela Shergold. I'm the Senior Manager of Development at the Lung Health Foundation, the leading organization dedicated to ending gaps in the prevention, diagnosis, and care of lung disease in Canada. Before we begin, if you have any questions specific to your lung health journey, our certified respiratory educators, or CREs, are ready to support your questions and concerns when and where you need it most. We encourage you to call the Lung Health line at 1-888-344-LUNG or 5864, or email info@lunghealth.ca to speak with one of our CREs today. Each year, we brace ourselves for the flu season. This year has been no exception to the rule, with influenza and other infectious diseases filling up our emergency rooms. As cases continue to rise across the country, there are steps we can take to protect ourselves, which brings us to our discussion today around the influenza vaccine. Today, I am honored to introduce Dr. Dawn Bowdish. Dawn is a Canadian immunologist and currently professor in the Department of Medicine at McMaster University in Hamilton, Ontario. She is a Canada Research Chair in Aging and Immunity and is also one of our very own as a member of our board of directors at the Lung Health Foundation and continues to provide expert advice to Canadians. We are grateful to you, Dawn, for taking the time for such an important roundtable today. Dawn is here this afternoon to answer some of the more common questions that we hear and some that you at home might have about the flu and any myths or misinformation you may have heard about getting your flu shot. The Lung Health Foundation works tirelessly in our mission to improve the lung health of Canadians, and that continues here. Lung health starts now. Dawn, over to you.
So thank you for giving me the honor of being here and having this discussion with you. Of all the years to get a flu shot, this is probably one of the most important. So I'm so glad that we're able to have this discussion. We already spoke this. This is what the picture as of 2 weeks ago, and it's a little bit more grim, looks like now in Canada. So the darker the color, the more influenza. And what you can see is that most of our province are having what's either called widespread, meaning so much influenza that it's throughout virtually all communities, or localized. And again, this is about 2 weeks behind the current data, which suggests it's even more widespread. This is very unusual. It is unusual to have so many provinces in Canada in the middle of an influenza pandemic at the same time. Let me walk you through what a normal flu season looks like and what this flu season looks like. So this graph's a little bit complicated, but I'll show you what it means. We measure flu seasons by weeks of the year. So the 35th week is the start of September and January 1st is the first week. In the black line there that runs across the bottom of the screen, that means that 5% of the tests in this country have shown to be positive for influenza. And once we hit that threshold, it's called an influenza epidemic. In the gray, the dotted line with the gray around it, that's a summary of what all sort of normal pre-pandemic years of influenza look like. So what you can see is that the average, that dotted line, would mean that we would be expecting the peak of flu season to be happening sort of post-Christmas in the New Year season, and to have this really sort of protracted period where there's quite a few infections into March. Then we would see the decline. Now, what you can barely see, there's a red dotted line along the bottom axis there, and that was the 2020 season. And because we were masking and social distancing, there wasn't much travel, there was effectively no influenza. Now, in the blue dotted line, what you're looking at is last year. And what's fascinating about this is influenza was still lurking about. There was some of the virus around. And as soon as we started lifting those restrictions and started mixing again, it gave it an opportunity to increase. And so that year, last year, was particularly unusual for having the peak in May. Now, if we look on the left side of the graph, at this year, which is in the dark blue, these are the data from about 2 weeks ago. And you can see that not only did we hit that threshold early, not only did we get to that epidemic particularly early, but you can see that the curve is steeper and it's still very much on its way up. We haven't hit that plateau stage. So this year's flu season is earlier, it's faster, and it's been extremely problematic. One of the things that's also not atypical is to have more than one flu strain in the circulation. So this year's mix consists of about 3/4 of them are a strain called H3N2, and about a quarter or 20% to a quarter are the H1N1 strain. One of the reasons influenza is causing such havoc right now is the very young and the very old tend to be more susceptible to H3N2. They tend to be less susceptible to H1N1, but more to H3N2. And so on the right-hand side, we're really seeing the evidence of that. So here, what we're looking at in this graph are the influenza hospitalizations. And what you can see is the steepest line, the most hospitalizations are occurring in very young children, kids under 4 in red, but a significant number of hospitalizations are occurring in people who are over 65 as well. So as with other influenza years, this is really an infection that leads to hospitalization in the very old and the very young. However, I'd like you to also look at the green, blue, and purple lines. So even in adults, healthy adults, between the ages of 5 to 64, we're still seeing a significant number of sicknesses and hospitalizations. And in truth, this is contributing to many challenges. Shortfalls in the healthcare sector as people fall ill or have to take care of children, workplace shortages, and other challenges. So the fact that we're seeing this many hospitalizations even in younger adults speaks to the fact that this is a particularly challenging year. I will also point out, though, that this is sort of a good news story in that the strains that were picked to create this year's flu vaccine were the correct strain. And so the efficacy of the vaccine is as good as it ever gets, which is at about 60%. And I'll speak to what that actually means in real life terms in a second. You've seen how steep that curve was, that influenza curve. And that curve is unusually steep. There's more infections than usual. And if you've been following the news, there have been far more hospitalizations than pre-pandemic times in the very young and the very old. There have been lots of theories and quite a few myths about why this might be the case. And I'll share with you some of the major points that people are thinking about right now. One of the things that is sort of in the pre-pandemic world was normal was that our different respiratory viruses had different curves. I showed you the influenza curve, but if I was to show you the curve for RSV, which causes a similar illness, you would see that it actually seems to happen February, March, April. So there's not much of an overlap there. We also have rhinoviruses, which we call them common cold viruses. But like every virus, they can cause a range of disease. They can trigger very serious asthma or COPD exacerbations and be quite problematic in people with pre-existing lung disease. That one has sort of a more steady curve, and the rhinoviruses are more resistant to masking and all that other social distancing we do, because they're actually those viruses that are resistant to sort of alcohol cleaning and things like that, and you can get by touching your face or whatever. Of course, we still have SARS-CoV-2 in the mix as well. And so this is the year we're calling the everything everywhere all at once year. Because there are so many viruses in circulation at the same time, co-infections are more common. And the data is crystal clear that getting 2 of these viruses, for example, COVID and RSV, or influenza and RSV, or influenza and a rhinovirus at the same time is more problematic. Oftentimes, the immune response you need to deal with one is less effective on dealing with the other. Children have been famous for getting co-infections since the beginning of time. But because there's so many of these viruses in circulation now, adults and older adults are also getting these co-infections. So one of the reasons that this year is particularly severe is the strain on the healthcare system and just not having the resources to help. The second theory, or the second piece of evidence, suggests that these co-infections are higher and co-infections are more challenging to treat. There are some other theories as well. For example, the lack of fever suppressing medication is believed to contribute to at least some of the challenges with children. Imagine if any of you are parents dealing with a toddler or a baby who's got a fever. Fevers suppress our appetite and make us not want to drink. So what can often happen if a child is running a fever for many consecutive days is they won't eat or drink. The theory is that when parents had access to fever suppressing medications, the kid would feel a little bit better, and then you'd be able to get some liquids in them. And so some of the hospitalizations are believed to be due to dehydration because children aren't being able to suppress those fevers, or parents don't have access to those medicines. There are other theories, including the one that the years of masking that we've had have led our immune system suppressed. And this one is categorically false. We know that for some infections like RSV, a person's first exposure is generally the worst one. Not always, but generally. And so it is true that kids who normally would have been infected when they were babies or 1 or 2, but didn't have so much RSV because we were all masking, are now getting sick at 3 or 4. It is untrue for influenza. Influenza, your previous exposures don't necessarily have any mitigating effect on your next exposure. And it's certainly not true with SARS-CoV-2 as well. So collectively, there's a few differences in this cold and flu season. And we don't have all the data to understand exactly why it's so severe. But the combinations of co-infections and all these other challenges likely contribute. Sorry, my slides aren't advancing. There we go. All right. Another challenge is that we've seen rates of influenza fall over the course of the pandemic. The graph that I'm showing you here speaks to vaccination rates in the various age groups. Now, older adults have always been the most committed to vaccination, probably because they see the most direct effects and the challenges of getting sick in mid to late life. However, Canada has set a goal of 80% vaccination in all populations, and you can see that our older adults aren't reaching that. Fortunately, older adults have remained committed to vaccination, and at least we're not seeing a decline. But when we look at younger people, including those with health conditions who definitely need to be vaccinated, we're also seeing decline. And again, there's a few things that are at play here. One of the ones is just the challenge of getting to a healthcare setting right now. We still have many Canadians who don't have a primary care physician. Vaccination may be not on their top list of priorities with all the other challenges. And in fact, many people, many practitioners in the community aren't aware of some of the chronic health conditions which would make a person a priority for vaccination. We also don't fully understand if the vaccine hesitancy that's influenced the uptake of COVID vaccines has led to a decrease in uptake in influenza vaccines, although preliminary data suggests that they seem to be somewhat independent. The fact of the matter is, though, vaccines work the best in the young adult immune system. As we get older, there are features of the aging immune system which make especially the influenza vaccines slightly less effective. So the important point of setting this goal of 80% for everybody is because those healthy young adults or people under 64, by being vaccinated, they cut down the burden of disease so that virus doesn't find an opportunity to infect the very young or the very old. Who is at the highest risk of a serious infection and should be a priority person for vaccination? Well, young children, very much so, and we've seen that through hospitalization. Influenza is very problematic in young children and can lead to very serious health consequences. And there is no value from an immunology perspective of having a child be infected with influenza without the backbone of a vaccine to provide them the protection they need to keep them out of the hospital. One of the things I think people aren't aware of is how difficult a serious infection like influenza or pneumonia is on your entire body. So people who have respiratory issues or cardiac issues are at high risk of having complications. And those complications might not just occur at the time that they're infected, but it will complicate their care and their condition afterwards. People with diabetes are at higher risk of severe outcomes, especially people who are challenged to control their blood glucose. And obviously, people with cancer who are on immunosuppressive drugs are at high risk of infection. People with kidney disease and various blood disorders, and even people who have neurodevelopmental challenges or people who are morbidly obese are also at the high risk. These are priority populations for vaccination. I'm going to show you some data in 2 slides about the importance of influenza vaccination during pregnancy. One of the amazing things about pregnancy is that when a mother is vaccinated, she can pass on those antibodies to her baby to give that baby a few months of protection through the placenta, or if she's breastfeeding through the breast milk, and help protect that baby. So not only does it protect mom, but she can pass that protection on to a baby as well. Now, people who are living in congregate living, things like nursing homes or chronic care facilities, are at high risk for 2 reasons. One of the ones is that they're a little bit more frail and they may have other health issues that make infections worse. But the other challenge is they live in the congregate living setting. The terrible loss of life and incredible infection rate in COVID and long-term care has highlighted a problem that has been in Canadian congregate care settings for decades. A little known fact is Canada has one of the highest rates of respiratory infections in these facilities for all the reasons we learned about in COVID: lack of infection prevention and control practices, issues with ventilation, and overcrowding. These are priority people for vaccination. As well, Indigenous people, regardless of their age, and if they fall into that higher age category, are at higher risk of serious outcomes for influenza and are a priority population for vaccination. The scars of colonization have meant that Indigenous peoples in Canada have worse outcomes than people who are non-Indigenous. And for this reason, targeting vaccine for this population is extremely important. One of the myths about influenza vaccine is that it makes you sick. And I would like to walk you through how vaccines are made and approved in Canada to explain why that isn't the case. So in Canada, we have 4 different kinds of vaccines that are approved for use, and they're made by many manufacturers. For those of you who remember the sort of controversy during the COVID vaccine period of mixing and matching different vaccine types, as an immunologist, this never worried me because we've been mixing and matching our flu vaccines for years. There are all these different types of flu vaccines, and each province will make a decision about which one they want to purchase and use. And so it's entirely possible you've had influenza vaccines from multiple manufacturers over the course of your own vaccination journey. So let's start on the left-hand side. One of the ways that manufacturers make the vaccine is called a split inactivated virus. Effectively, what they do is they grow the virus up and then they use detergents or other ways to break it into little pieces. And in this way, it shows many different pieces of the virus to your immune system. On the top there, we have new this year a recombinant vaccine. And this actually makes some of the proteins that are on the surface of the virus. And the innovation here is it's not made in eggs, whereas most of the other vaccines are. So this is a vaccine that would be suitable for people who have egg allergies and can't be vaccinated with some of these conventional ones. On the right-hand side, we looked at what are called subunit proteins or subunit vaccines, where these small proteins that are on the surface of the virus are made and purified, and then we're used to vaccinate that. And at the bottom, we have the live attenuated influenza vaccine. This is also called FluMist commonly. And in this case, there is a whole virus in there, but it's been treated in such a way that it's very weakened. This one is usually administered as a spray in the nose. My children call it the sniffer, and it is particularly effective in children and also is one of It's the only vaccine currently approved that doesn't require a needle, so very appropriate for needle-phobic people. Like I said, one of the common myths about influenza vaccines is that they make you sick. And in truth, there are two reasons why this happens. We get vaccinated during cold and flu season. So in studies that have looked to see and follow people who get vaccinated and the side effects they have, some of the people who report getting sick from their vaccine actually have a completely unrelated virus that they just happened to get at around the time that they were vaccinated. The other feature is the other reason that people feel this way is because the vaccine response stimulates the same type of immune response that you have when you get sick. The whole point of these vaccines is to confuse the immune system into thinking you're being infected and mounting an immune response. So what happens is the fever, the achy, aches and pains, the sore arms, that are all part of this are very much evidence of an immune system that's working, not one that's making you sick. And because, with the exception of the flu mist, none of these actually have a viable virus in them that could infect, there's no way to be infected by the vaccine itself. I'd also like to point out that these vaccines can be tailored to best use for different populations. So as an example, the live attenuated vaccine, the inhaled vaccine, the mist, is primarily used for children and works exceedingly well in children. Many of the other vaccine types have special formulations for older adults. The immune system of an older adult generally needs a little kick, a little punch to get it to do the same thing as that of a younger adult. And so as a consequence, we have either a high dose where we have a little bit more of the vaccine ingredients in them, or there's a special what is called an adjuvant, which also gives the immune system that little kick. If you were a young person and were to get one of those high dose or adjuvanted vaccines, nothing bad would happen, but you'd probably feel it a lot more because your young immune system would give you that really achy feeling. But for older adults, that extra kick helps make it more effective. Now, as I said, this I think is really confusing for providers and for people who are making speaking to people directly about these, because each province will make a decision about which one to buy and which one to administer, and they're not the same across the country. So some provinces one year will buy one from one company and the next year buy one from a different company. And this means that there's a little bit of heterogeneity across the country about what are available. Flu vaccines are good, wonderful tools to help fight this. And yet we still struggle to a certain degree with people who are not getting vaccinated. Now, like I said, we're not seeing a lot of vaccine hesitancy, distrust of the vaccines with flu vaccines. Most people feel that they're probably pretty safe and reasonably effective. And these are the top 3 questions people get for why didn't you get your flu shot? The most common one, and it's the one I hear all the time in the context of my work, is that I'm healthy and I never get the flu, so why should I get a flu shot? I think the best answer to this is that previous experience with influenza isn't necessarily a predictor of what your future experience with influenza is. You may be exposed to a strain that knocks you right out, even though you never had that experience in your life. And I'd also point out that every year we get a little bit older and move us up into that vulnerable category. So even if you historically have never had a issue with influenza, you may as you reach that older adult category. So I think the messaging that we need to use is that past experience doesn't necessarily dictate future experience. As well, there are 2 categories of people who feel that a vaccine is a personal health decision that they make to keep themselves healthy. The second category believes that that is probably true, but they need to be vaccinated to protect the people around them. And that is true. Even if you are a healthy person who's not going to get this year's flu shot, there's no guarantee that you're not going to be a carrier and bring it to someone else. So that's 2 ways that I address this idea that you've never got the flu, so you never need to get a flu shot. But honestly, most of the reasons are just sort of apathy, not getting around to it, not making it easy. And this is where things like having pharmacies involved is so crucial, because I think most of us would acknowledge that it's a lot easier to get into a pharmacist for a vaccination than it is to get to our primary healthcare provider. And having things like workplace campaigns make it very, very easy. There's a little bit of not peer pressure, but certainly if everyone's going to go get their flu shot, then that's sort of encouraging as well. So one of the things that we need to think about is how can we make it easy for people to get that flu shot? Even if a primary care provider recommends getting a flu shot, the following up and seeing that someone goes through with that can be a real challenge. So one of the things that we really need to think about is how to make these easier for people. And I want to give you a little bit of context about why influenza vaccination isn't just important for the here and now, but for your future health. Many serious viral infections, including RSV and influenza, are associated with having an increased risk of bacterial pneumonia in the downstream. And let me explain this. Some of the immune responses that you need to get over that initial viral infection, actually, when they sort of come down, they lead to this period of suppression of the immune response, and bacteria can take advantage of that. The example we always use in teaching is in the 1918 influenza pandemic. The majority of those deaths were not due to the influenza at all, but to the bacterial pneumonia that followed it, because of course this was a pre-antibiotic era. So for those of you who maybe don't feel you've ever had influenza, but have had a bacterial pneumonia, even a mild infection can increase that bacterial risk. And for those of you that are following the international news in this area, you'll know that in the UK, there have been many, many reports of an increased risk of strep throat and even some deaths due to streptococcal bacterial infections, again, coming after some of these viral infections. We already know in Canada that antibiotic prescriptions are far, far, far higher than seasonal averages. And this is believed to be a follow-on from the incredible viral load we're having this season. So protecting yourself and not getting that infection in the first place also means that you will be protected from the downstream effects of bacterial pneumonia or other bacterial infections. The second thing influenza vaccination can protect you from is cardiovascular events. There has been epidemiological data for as long as we've been doing epidemiological studies showing that after a serious influenza infection, heart attack risk increases, and that risk increases for quite some time. Both the immune response and features of the viral infection can lead to this increased risk of cardiovascular disease. And for those of us who are either in late life or caring for someone in late life, there is a very real possibility that an influenza infection will be accompanied by muscle loss, will be accompanied by a lack of activity. And so you so often hear of older adults having health issues that come after that because the recovery time is so difficult, including falls, including having other health issues flare. And this is associated with an increased rate of frailty and disability, especially in people in late life. So influenza vaccination actually protects from a myriad of other health issues. And I need to address pregnancy because one of the challenges that we are seeing are decreased vaccination rates for pregnant women. And this is leading to hospitalizations and challenges with both pregnant women themselves, but also challenges for their babies. The tremendous amount of energy it takes to grow a baby means that when a woman gets infected during her pregnancy with a serious infection, we're not talking the common cold or the sniffles here, but influenza, COVID, RSV, she is sometimes at a high risk for both herself and her baby. And in fact, having a serious infection during pregnancy is associated with miscarriages, smaller babies, because that energy that mom needs to survive that infection is then taken away from that baby. Complications in pregnancy and delivery, including all the scary ones that every pregnant woman worries about. And furthermore, all that inflammation to deal with that infection interferes with processes such as brain development, And so a serious infection is associated with an increased risk in neurodevelopmental disorders in babies born to those moms. Vaccination is completely safe during pregnancy. It's not only safe, it's essential to keep babies healthy, both as they're being born, but also to pass on some of that immune protection to those babies for the first 6 months of their lives. Now, I mentioned how influenza and pneumonia can be hand in hand. And so if you're older than 65, or if you have a chronic health condition, great to think about these as a pair. And so I'd really encourage you to think about both the flu shot and the pneumococcal infection to really knock out pneumonia, because those are two vaccines you definitely want to have in mid to late life. So with that, I'd like to wrap up me talking and address some of the questions that you might have in the chat.
Thanks, Dawn. I'm going to facilitate some of these Q&As because they're coming in through Facebook and also through here, and we have some ourselves. So I'll get to the ones from our audience first. You had a slide about the types of vaccines out there, and I think, publicly we've gotten very comfortable with knowing that different brands make different products that become available to us. We have a question on Facebook. Is any one type of vaccine more effective than the others?
Yeah, I think one of the things that's a little bit disturbing to know is that by the time, here's how the vaccine manufacturer comes. So first of all, we have surveillance group that work primarily in the Southern Hemisphere to say, okay, what's circulating right now? Let's make a prediction. Then how this goes is those strains will start to spread a little bit and manufacture will start. Because most of our influenza vaccines are actually grown in eggs, you can only do that so quickly. You can only make so many eggs and you can only have them so quickly. So there's a few months that sort of pass as this is being made, and the vaccines are purified, shipped to the Northern Hemisphere like us, people get vaccinated. And we rarely do a side-by-side clinical trial to say, okay, who did better? Was this vaccine better or was this one better? Because by the time we did that, the flu season would be over. So one of the challenges of getting that perfect kind of data is that every year it's a little bit different too. Different manufacturers will make slightly different decisions about that. So we have to look retrospectively. So it's challenging to tell you what the go forward is, but we can say looking back on a few things that are really key. Older adults definitely need to have access to the formulations that are specific to them. If we take the same flu vaccine and we gave it to the very young and the very old, generally we hit an average about 60% protection. But as you get older, that falls down. The only way to get those levels up higher is to use those high dose or adjuvanted ones. And depending on what province you're from, some years those are available, some years they aren't, sometimes they choose to invest in not. And I think this is such an important thing to lobby for access to these high dose and adjuvanted vaccines, because the very people who are vulnerable need them. The other piece of data to support what you're asking about is the use of flu mist in kids. So that inhaled vaccine seems to work exceptionally well in young children. However, again, not every province offers it every year and can be a little bit variable. So one of the things that if you are an advocacy-minded kind of person we really need strong advocates to make sure we're using these vaccines to their best ability by getting the right vaccine to the right group of people at the right time.
Great, thank you. Few more questions coming in. I'm going to jump to the Zoom questions. Could you comment specifically among seniors on the amount of B strains circulating and the situation with B Yamagata?
Yeah, so I'll just go back to the slide we were looking at just so people have something to look at about the two different ones that are currently in circulation. So every year this mix is slightly different. So oftentimes we have a little bit more of one strain, a little bit more another. In general, for the past pre-pandemic years, we've had more of the sort of influenza alpha, the H3N2 strain circulating that affects younger and older people. If the phrase H1N1 sounds kind of vaguely familiar to you, you might remember it from being the pandemic year. We had a particularly dangerous strains of H1N1. And what's the research is kind of fascinating about the various relationships between these viruses and who they're going to affect most. As it turns out, some of our older adults, when they were very young children, dealt with something that looked very much like the pandemic strain that we had in 2009. And as a consequence, when in 2009, 2010, when we had that really dangerous H1N1 year, some of the oldest old actually did way better than we would have expected. Our vaccines are very effective at dealing with H1N1 strains in general. And so in that strange pandemic period, we learned a lesson that sometimes, these childhood exposures could have an effect very late in life, but the rest of us really need a good vaccine. Otherwise, we'd be in big trouble. Right now, hospitalizations for older adults are still primarily the H3N2 version, but that may switch as the season continues. We may start to see that the other strain sort of takes over in older adults and things like that as children sort of finish their major peak of infections and hospitalizations. I think the other thing that, if we're thinking about these different strains and how they're going to affect the population, let us not forget that the holiday season is a major transmission event from children to grandparents. Hospitalizations for bacterial pneumonia and serious respiratory infections in older adults, especially those living with COPD or other chronic health conditions, peak during the holiday season. And this is not due to the virus, this is due to human nature, right? So we bring families together, and if the kid has some sniffles or, we think they're probably okay, we get together and we see that transmission. And so I think everyone's waiting with bated breath to see what this season's going to look like. And if I had to guess, I think that orange and red line of the kids and the older adults may switch after the holiday season as we see more of older adults getting hospitalized. So again, this is the year to get those kids vaccinated and to take precautions if anyone's got symptoms.
That's a great point. There's a couple of questions that we do have actually around that. So is there something else that we can expect as we head deeper into the holiday season, deeper into the winter season, so January, February as well? And then a follow-up to that as well. If somebody does come into your home during the holiday season and they don't have the flu vaccine, is it a low risk if they're wearing a mask, washing their hands, following other public health measures?
Great questions, both. I guess what we're looking forward to, and what's still a little bit unknown, is this going to be a fast and hard season where the peak goes up and the peak goes down? Those are rare. Those are very rare. So generally what tends to happen is the rates go up and then they stay up for quite some time. So I don't think we're going to see a major decrease before the end of February, where we start to really see that taper off. But, some places are, making different rules about masking, things like that, so we never know. So we can't expect a really protracted period where there are quite a few infections. So how do you protect yourself? And while being reasonable, because we all want to get together for the holiday season, and this is so important, especially after so many years of not being able to do that. Remember that these viruses are primary respiratory. So they tend to transmit mostly through the respiratory, less so through the touching thing. Masking is great. The challenge is that you're at your most infectious before you have the symptoms, right? Because you have these big viral loads and you have to remember all the symptoms, the coughing, the sneeze, the runny nose, the feeling poor. That's when your immune system kicks into action. But if you don't have a vaccine in your back pocket, it can take a few days to kick into action. So if you're really concerned, masking is probably the best thing you can do. The hand washing is also really important. You can try to ventilate your space as much as you're able. Super difficult in Canada in the winter because to ventilate, you need to have open windows and a fan, and that's cold. There are things like air purifiers and things like that you can also try to do to reduce the risk. But I think to be reasonable, smaller gatherings, just reduce that risk, being really vigilant about symptoms and not socializing if anyone has symptoms, and keeping in mind that healthy adults and young kids often are mildly symptomatic. So any symptoms, you might want to lock that down, and masking. And I think that's the best we can do.
With that, knowing that, we'll probably see this peak until the end of February, Also knowing that boosters are being promoted for the COVID vaccine. Is there an ideal time to get vaccinated against the flu? We don't really see a lot of promotions publicly other than through the Lung Health Foundation post holidays. So what are your thoughts around that?
Absolutely. So your peak immune response is about 2 weeks after your vaccine. So if everyone were to run out and get vaccinated today, if September 25th or December 25th is the day you celebrate, you'd be in a really good spot for that time period. So, I mean, you can time that, 2 weeks before your peak protection. I think one of the things that the public became aware of, but had always been known in the vaccinology field, is you really get a maximum of 6 months for your vaccine to be totally effective. And that's true for COVID, and it's also true for influenza. The reason that we only have one flu shot a year is because historically we have one peak, we have one season, and it lasts about 6 months. So if everyone gets vaccinated at the beginning, that carries us through. If in some alternative universe there were 2 peaks for influenza in the summer, you would need a second shot. Putting this in the framework of COVID, again, we have to think about getting vaccinated at the beginning of these waves because the least likely you want it at the beginning of the wave. This is a great time to get vaccinated for both. And I think it's important to keep in mind that you get maximum 6 months of protection. So make sure that you don't run out of that time when infections are high.
Great. A couple of other questions are coming in here. One around, we heard a little bit in the media at the beginning of the pandemic about COVID arm when vaccines were being launched. Is there flu arm post-vaccination?
This is a great question. I actually had COVID arm myself with my vaccine. Yes. And I took pictures because this is amazing. I'm going to teach this in my immunology class. This is immunology in action. This is wonderful. So COVID arm, just to give everyone some context. So there's 2 things that happen with vaccination. One is that swelling, sore muscle, really, really achy, and it can be quite bad and quite painful to the point where you might feel the need to take a Tylenol or to limit your movement. That's because when you get that vaccine, your immune system is all heading to that direction to get everything started. And with that, if you imagine there's some swelling as sort of liquids get into your muscles. That's sort of a normal standard thing. With the COVID vaccines, there was often this rash that was associated, especially with sort of first to second doses. And that rash could actually be quite painful. And that seems to be exceedingly rare with influenza vaccines, much more common with COVID vaccines, still rare, but much more common. Very rarely a feature, at least with the current formulations we have of influenza. Having said that, there are mRNA vaccines for influenza in the works, so it'll be quite intriguing to see if those end up being more commonly associated with COVID arm.
Great, thanks. I'm going to jump a little bit back, more specifically about the influenza vaccine. Are there any risks associated with getting the influenza vaccine?
I'm glad you asked, because I think it's important to be frank and forthright about the risks of vaccines. Everything comes with a risk, and vaccines are no exception. So in the very rare cases, there can be things like Guillain-Barré syndrome or other syndromes where the theory is your immune system in its sort of normal repair gets the signal that there's an infection and that the thing that they are repairing, they start attacking. So very rarely you can have these disorders where the immune system can attack, especially human nerves seem to be quite susceptible. It's rare, exceedingly rare, but it can happen. Those are sort of the major high risk things that are associated with the influenza vaccine. And I think one of the challenges is feeling really poorly. If you're one of those people who does poorly with your vaccines and being sick and being achy, having the rash and the COVID arm or the influenza arm or whatever, are not considered serious because they're transient. These rare things are things that can be semi-permanent. Having said that, there is nothing that happens in the context of vaccination that isn't more common during infection. So all those rare and dangerous and scary things can also happen during a severe infection. So if you were to do the risk benefit analysis, there's very rarely a case where it doesn't come out in favor of vaccination.
So the benefits clearly outweigh the risks here.
All the scary things that you've ever heard of with vaccination can also happen, but more frequently with infection.
More frequently if you get it, correct. Great. What other measures, are there that people can take to protect themselves from the flu?
Well, I think the masking has just been shown to be incredibly effective. I mean, in 2020, we were actually having a pretty terrible year for influenza, RSV, and other respiratory infections. And masks came and social distancing, and the curve just went straight down. So I'm still masking inside myself and taking precautions those ways. I think it's important to protect my community, especially all the children who are now being sick and hospitalized. So masking is one of the most effective things we can do. Having no tolerance for going to work sick. I mean, it's so crazy to me that we still don't have really standard sick leave policies across this country, so that some people still feel they have to go into work sick, which is really very problematic. And as well, I have all the sympathy in the world for working parents who have the challenge of not being able to take time off and sending the kids to school sick. So staying home when sick is really important. Masking is really important. Obviously, hand washing and hand hygiene is important, but let's make sure we keep the relative importance clear that, breathing is the primary method of transmission. Those are the kind of things we can do. And I would also say, if you have a chronic health condition, the better managed it is, the better you will do with any respiratory infection. So as an example, if you're a diabetic whose blood sugar goes up and down, you're at much higher risk of serious outcomes. So have those conversations. If you have a respiratory issue, make sure you're seeing your respirologist or your primary care, because the better health you are in, the more likely you are to have fewer complications. Many people have shared with me that they're not going to go see their family doctor and aren't taking care of those underlying conditions because they don't want to burden them. Things. If your family doctor were here right now, they would slap you on the hand. They want to see you because it is so much easier to deal with things early than to have somebody get seriously sick. So do not delay. Do not delay managing those chronic health conditions. It's really, really important that you do that.
And this is a part of management, a critical part of management there.
Absolutely.
With that, we know a lot of people don't have access in Canada to a primary care provider. Where else can they go to get the flu shot?
Yes, this is a great and important point, and one thing we all need to advocate to improve. Pharmacists are incredibly empowered to do so many vaccines. And in fact, most of us live closer to a pharmacy than we do to our primary care providers. So pharmacists are an incredible resource, very, very knowledgeable, extremely experienced. If you have questions, they have lots of information about your personal challenges. So I'd really say using our pharmacies are good. Many large workplaces have employee programs, which have been shown to be very, very effective in getting people vaccinated. And there are clinics, public health clinics that are available. So many jurisdictions, including my own, have clinics available where you went to go get your COVID shot, you can go do a flu shot now. Unfortunately, you have to do a little bit of internet searching to find those places, but those are all options as well. And, I think for those of you who are fellow advocates with the Lung Health Foundation, these conversations are important conversations to have, because access is one of the key reasons that people don't get those shots.
We do have some advocates that I see registered in here, so it's a great message. I'm just going to look through here. Is there any time between getting your COVID vaccine and your flu vaccine? Should we be waiting? Can we get them at the same time?
Great question. In the early days of the COVID vaccines, we said no other vaccines for 3 weeks. And that wasn't due to biology. That was due to the fact we had a really serious monitoring in place because these were new vaccines. You know, we had to get information about side effects. And if you had them at the same time, it would always be a little bit confusing about which side effects or which vaccine that was associated with. So last year, the National Advisory Council on Immunization lifted that. With over 1 billion doses served, there were no more surprises with regard to COVID side effects. And so then the recommendation was that you could combine them into the same visit. And there's really no reason not to do that. Your immune system is the ultimate multitasker. You are dealing with many, even as I sit and speak, my immune system is busy working on many, many, many different things. So there's no reason to be concerned about that. I think, sometimes people with small children, especially if their kids are sort of the kids who get feverish or really ill with their vaccines, which is not uncommon because they've got those wonderful, strong immune systems, want to spread them out because they're worried about those getting worse. So if that makes you more comfortable, then by all means do that. But there's no biological reason not to get your COVID and your flu shot at the same time.
Thanks. That's great information. I'm going to close with one question, which is probably the biggest myth that we hear, and I know you touched upon it in your presentation. Can you get the flu if you've gotten the flu shot?
You can get the flu. These vaccines are not perfect, but the good news is your chance of having a serious infection goes low. Your chance of having a heart attack decreases. Your chance of going to the hospitalization decreases. Your chance of having pneumonia decreases. So although, yes, there is no such thing as a perfect vaccine that is 100% effective 100% of the time, you will be better off if you've got the strong backbone of a vaccine telling your immune system how to deal with this infection. You may get sick, but you will get less sick, and your chance of having all those bad things happen will be decreased. It's not perfect, but it's better than not being vaccinated.
Great, thanks so much. If I could summarize today, we know that our older adults and our younger populations are at highest risk of complications and should be prioritized for vaccines, but everybody should be getting vaccinated for influenza. And if you have questions, we've got our CREs, and you have healthcare providers, your primary care provider. We've got great resources here, like Dawn. But if you don't have that, you can always contact us at lunghealth.ca. All of our contact information is through there. Dawn, thank you so much for agreeing to host our roundtable today. I think we've all learned a lot. There were some great questions and engagement, both through our Zoom and through our Facebook Live. I also want to thank our organizational partner, Sanofi, and of course, thank you to everybody who attended. Again, a reminder, our lung health line is available if you do have any questions. Also talk to your doctor about choices that would be the best for you. We hope you got something out of today's session, and we are always here for you. Visit us at lunghealth.ca for more information. Thanks so much, everyone. Have a great day.